My name is Tom McGrail. I'm the Director of Clinical Services for King Systems. We'd like to chat today a little bit about the King Airway, sometimes called the King Tube. The indication for the King Airway is for airway management to provide a patent airway to allow patient ventilation. Obvious contraindications are an intact gag reflex. Obviously you can't put it in if they're still gagging, or if they've ingested a caustic substance, or if there's known esophageal disease. It's available in two iterations. The original version was just a single lumen. It's actually the King LTS-D, laryngeal tube disposable. Has two cuffs and ventilatory openings in between. The other version, probably the more popular version now, is the King LTS-D, and the S actually stands for suction or secondary lumen, so it has an extra lumen to allow accessing the stomach. And again, this is on the back side, allowing up to an 18 French gastric tube to be placed into the stomach, capturing on the fact that the tip is already in the esophagus. The original version is available in 5 sizes. They're sized by height, go from about a 12-kilogram infant up to the largest adult. The LTS-D is available in 3 sizes for adults. We'll talk about this later. There is a lot of overlap between the sizes. Again, how this works is there's 2 cuffs with ventilatory openings in between, not unlike the combi tube that has been around for years. But you'll see that the curvature is a bit different. The combi tube has 2 inflation ports for the 2 separate cuffs. There's only 1 on this. There's 2 ventilation ports here, only 1 on this. So how this works is you're just inserting it blindly. It's a supraglottic device, and you're wanting to put the tip into the esophagus. And in this case, it's going around the bend, and the distal balloon is sealing in the esophagus, and the proximal balloon is sealing above the airway in the oropharynx. And when you inflate both cuffs, it seals off those respective areas, and you can see the airway openings are here ventilating the airway. So that's how it works. Both the King LTS-D and the King LTS-D are available in a kit, which includes the airway itself, a syringe, 60 cc for the adult sizes, 35 for the peds, some lubricant, and a quick reference card that includes brief instructions and sizing information as well. There are essentially 3 key aspects in the use of the King Airway. The first is the actual insertion into the mouth and getting it around the corner of or around the base of the tongue and getting it towards the esophagus. Do a chin lift and control the tongue. Introduce the tip at roughly a 45-degree angle. And with one free and easy motion and without exerting undue pressure, advance the tip behind the base of the tongue, rotate it back to the midline, and advance the connector to the teeth. At this point, inflate both cuffs with a full syringe, 60 cc's, 60 to 70 for adults, 30 to 35 for the pediatric sizes. Connect the resus bag or breathing circuit in the OR and assess ventilation. And if you do not get an airway, retract slightly until breathing is free and easy flowing. If there is a slight leak at this point, you may need to actually add a little bit more for those larger patients. And at this point, it would also be good to use tape or other accepted fixation to make sure that the tube is stabilized before moving the patient. And then for the version with a gastric access port, clearly if you would like to, or it's indicated to pass a gastric tube and decompress the stomach, now is the time to do that as well. There's several other things you can do in addition to the chin lift. Clearly, if you're using this as a backup to intubation, it's very easy to insert if you can use a laryngoscope. Again, you're controlling the tongue. And again, one smooth motion, inserting it in place. To illustrate this alignment of ventilatory openings, I've got this model with a cutaway. And so you can see that as this is inserted in, and you end up going too deep, and with the balloons inflated, you can see that this balloon is actually occluding the airway opening. But as you withdraw this, then the openings are exposed and you can now ventilate. So this is exactly what's happening when you do it in a patient. This alignment procedure accomplishes a couple of other important things. I mentioned there's three sizes, three adult sizes, but the tube shaft is the same diameter, the cuffs are approximately the same. So the only difference is length. Obviously a taller patient is going to have a greater distance from their teeth to the laryngeal opening. So this alignment procedure where you go in too deep, it essentially accommodates a taller patient or someone with a deeper larynx than you might have been anticipated. And obviously if you have to retract it more, that would accommodate a shorter patient than what you expected. And if you have to pull it all the way out before you start to get some airflow, then something's got to be wrong. That would be an indication of the highly unlikelihood that the tip had actually entered the trachea. If the King airway is going to be left in place for an extended period of time, more than a couple hours, it just makes common sense to make sure that the cuffs are not overinflated. We recommend using 60 centimeters of water pressure for the cuffs. This is a nice balance between getting a good ventilatory seal and not creating long-term sequelae. If you do not have a pressure gauge, then clearly what you need to do is, as you're ventilating the patient, listen for leakage and gradually decrease the cuff volume until you just get a leak, and then give just a little bit more to seal it off. So use a just seal condition. I would like to touch on several frequently asked questions in regards to the King airway. First of all, we often get, well, does this prevent against aspiration? Well, I refer to this, this cross-sectional model again, and the function of the oral pharyngeal cuffs and the esophageal cuff and sealing above and below the airway inlet. As we saw, it gives a good ventilatory seal. There is a low likelihood of insufflation of gases into the stomach, and so clearly there is some protection against rising stomach contents, but no device actually prevents against aspiration, not even a tracheal tube. The next question I wanted to touch on is how long can the King airway be left in place? And it relates to the comment earlier about making sure the cuffs are not overinflated. It's been used in the operating room for up to 8 hours. It's been used to transport military personnel out of Iraq and Afghanistan overnight. It's been used in the ICU for 2 to 3 days. The key is just to make sure the cuffs are not overinflated. The final frequently asked question is probably the most complicated, but also the one we get the most often, and that has to do with how do you exchange the King airway for a tracheal tube? And clearly, everyone is anxious to see that a bougie inserted through the King airway is deflected anteriorly out towards the laryngeal inlet, and this could be a suitable way to exchange. However, I would caution that if this is done blindly, it's probably not the best technique. First of all, you need to remember that if you're able to ventilate and you're able to decompress the stomach with that gastric access lumen, hopefully you've got time and you can figure out what your options are. So this is certainly not something that has to be jumped into right away. We certainly hear of folks that leave the King airway in to do diagnostic procedures or send them up to the operating room even. The next step, or the first way to see is, can you, by deflating the cuff a little bit, actually visualize the cords next to the King airway? And it might be that you could just put a bougie in, and in fact I can actually see it here. So visualizing is certainly going to be better than doing something blindly. If you've got access to a video laryngoscope, this can actually help as well. Again, visualizing that you've actually placed something in the trachea. First, see what you can see by leaving the tube in place and trying to either put a bougie or tracheal tube outside the tube. The nice thing about this is you can continue to ventilate or at least oxygenate through the King airway itself. Next, certainly if you want to go through the tube, you can't see anything because the cuff's in the way or there's secretions or whatever. Then there's two other suggestions. One would be an Aintree tube exchange catheter that has a hollow bore that you can put a pediatric fiber optic bronchoscope through and visualize its placement in the trachea. There's also an ARNT tube exchange system that actually has a wire going through a fiber optic bronchoscope and then an introducer that goes over top of that, again visualizing that you're placing something in the trachea. As a last resort, this certainly can be done blindly, and it's following a similar procedure that we did for the original alignment of the ventilatory openings. And that is, start out too deep and just tap a little bit softly, and at some point it'll go, and hopefully you'll feel the tracheal rings as well. And at this point, assuming you'd be in the trachea, you can deflate the cuffs and it becomes a normal exchange at this point.